thrilled to be with you in 2023. This is the fourth calendar year that we've had a Crisis Jam. We started in September of 2020. This is our 108th show. And last year, the most sought after discussion was one of a special youth edition that would focus on the SAMHSA national guidelines for behavioral health crisis care, a best practice toolkit, again, for children and adolescents. And as with everything, we just take the adult version and stamp it with children and adolescents and we're done, right? No, that's not what we did. If we'd done that, we would have had this presentation, Anita, last February, right? Or March. But instead, no, forget that idea. That's not what we've learned in this learning community. We've learned that it's very much, and my slide's not doing its little dancing. Well, that's too bad. But we've learned that kids are not micro adults. We've got to come up with something that is unique and appropriate for them. And this whole theme we've had of care that feels like care to the person and getting into the worldview and experience of that individual with crisis care has really shown through in these national guidelines. And Dr. Anita Everett and Dr. Belina Shaw will be with us today, as well as a couple of other guests who will be joining us as we today talk about the in a full special youth edition. Our learning community continues to grow, and the Crisis Jams are not only attended by 250 to 400 of you every week, but many more of you are actually watching it on YouTube. The special edition we had with the Assistant Secretary, Dr. Miriam Delphin-Rittman, last July as 988 went live, continues to garner more views. And we're thrilled that this learning community continues to grow. Karen will drop into the chat text if you're interested in the Crisis Jam being on your calendar. There's an easy fix for getting that done, or if it's dropped away. And the easiest way to do that is to go to our website at talk.crisisnow.com. Not only do you see what's going on today as we come out of a 2-week hiatus with the Crisis Jam and what's going on for this week, the Zoom link is there, but you can also sign up for our newsletter. And that is what guides this learning community, is this communication between us. You'll get a weekly update on what's happening today. So if you haven't signed up for that, as well as the link to the t-shirts in the lower left and the highlights of the recent week, the video, as well as the trivia question, the presentation, et cetera. Now, I think it was in October, we had our 100th episode. And we featured Dr. Don Berwick, who came on, but we showed a video before the show started that came from the Ad Council and the Seize the Awkward campaign. It's the Whatever Gets You Talking video. We actually had a trivia question about that, and you'll see the answers A, B, and D. These are some of the most famous TikTokers, entertainers, folks on the planet, but largely unknown to many of us who aren't Gen Z. My son, actually, William Covington, came on as a video phone a friend, if you'll recall that episode. But Dr. Brian Sims from NASBID said, David, we really should show that video in its entirety in the Crisis Jam itself. And it seemed like a great time to do that. So we were talking about this concept of, do we just simply take our adult version and republish it for children and adolescents, or do we really get inside the experience? The Ad Council, the JED Foundation, I believe AFSP were involved in this video, and it's really gets us a different sort of experience. So let me see if I can make sure this is shared for sound. There we go. And we'll go to the Ad Council video. It's about 2 minutes long. And I was watching it again this morning. I do recognize a couple, but see how many These are all famous and well-known folks in the social media environment.
Worried your friend's struggling but don't know how to reach out?
You could say, how are you, or get a fake tattoo. You could ask with an app if it works for you. You could write them a text or knit them a sweater. If you can't be together, you could write them a letter. You could ask in a gift or ask in a dance. You could say, ça va, if you're friends from France. You could chat with them in VR. It's so good. If you think you should check in, yeah, you should. Whatever gets you talking. Whatever gets you talking. You could chat on the game, kick off your flip-flops. You could ask on your couch while you binge watch. You could ask during yoga doing downward dog. You could ask with headphones while singing a song. You could even ask while working from home. You could ask on a conference call, please hold. However you do it, you gotta ask a friend. And if they don't share, you can ask again. Whatever gets you talking. Whatever gets you talking. Ask with a puppy, a cat, a filter after a nap. You can ask with a note, a selfie, a quote, a playlist, a pizza, a work of art, a puppet while playing darts or while eating a snack. You can ask with flowers and talk for hours. Ask with a pose or send them something you draw. You can ask while you're chilling or dealing cards. However you do it, you gotta ask a friend. And if they don't share, try to ask again. Whatever gets you talking. Whatever gets you talking. Whatever gets you talking. Whatever gets you talking. Whatever gets you talking.
There are a lot of ways to reach out to a friend about their mental health. Learn how you can help at seizetheawkward.org.
So, Rep. Orwell, how many of those personalities did you recognize as we were going through that?
Zero, sadly, but I'm going to do my homework.
Well, my son, William, who's going to actually sit in the Crisis Trivia hot seat today. We actually have two special edition Chelsea Booth and my son, Will have two different Crisis Trivia questions today. But we'll recognize most of those, and that's really, it is focused on a younger audience. And in fact, Will, I don't know if you're on mute or not, but Will, I don't know if you recognize this park. My son, Will, and Sean, we actually walk at this park frequently. It's only about a mile away, but this was one of the featured photographs in the Washington Post article in December, which really did focus in on the Chandler Unified School District, as well as the issue of student mental health across the country. Dr. David Jobs actually just spoke. Dr. Jobs, I don't know if you're in the call today, but you actually came to as a result of this effort and spoke in Chandler recently after a number of suicides among high school students occurred. And Karen will drop the link for that into the chat text. The Kennedy Forum also just recently released a new policy brief on the behavioral health emergency services space, focused on 988, mobile crisis services, crisis receiving and stabilization, as well as prevention. They include the state model legislation and have a host of great materials in that, and we'll put the link in for that. If you haven't seen the JAMA article on mental health revisits at U.S. pediatric emergency departments, Matthew Goldman, this might be something we want to highlight during a coming data corner. I've seen a few articles recently from different angles on this issue of adolescents with mental health and substance use in emergency departments. But if you look down under results, the second sentence, mental health visits increased by 8% annually over the time frame. I think this is 2015 through 2020 that they were looking at it. They increased 8% annually for these mental health visits in pediatric emergency departments versus an increase of 1.5% annually for all other medical emergency department visits. And then our quote of the week, the latest on Damar Hamlin, is that he is making very slow progress this morning, is relying less on the ventilator. They're concerned about the impact on his lungs. But look, the only reason he is in that position to be recovering is because of this strikingly fast emergency medical response, with trainers who are professionals on to him within a 10-second sort of time frame. Dr. Sanjay Gupta commented on that. Just the time is of such critical importance here in terms of taking care of someone like this. The response from the medical team was fast, and seconds and minutes matter in a situation like this. Now, it's not a standalone. It's not just a one-off related to the NFL. This is the result of a 55-year effort, starting with a policy document, with those first 911 calls in 1968, and then going through this amazing system that we have nationally, with the expectation that we're going to get faster and faster with better and more standardized care to the person at the moment they demand it, because it makes a difference. So it's such an inspiration and analog for us as we move forward with 988, mobile crisis teams, crisis receiving facilities, and much more that the SAMHSA National Guidelines are going to lean into as we get going today. So with that, let's go to Dr. Anita Everett and the much anticipated SAMHSA Youth Guidelines.
Great. Thank you. Thank you, Dave. And thank you to this community for inviting us to come and talk a little bit about this document, this report that's come out. We're all excitement about a federal document. I think that's probably a good thing. So I want to thank everybody for that. I am the director of the Center for Mental Health Services within SAMHSA, and we do a lot of the support work for the 988 thing, including one of the projects that we're actually working on that David has been a participant in, as has Dr. Hepburn from NASHPD, is the ESMIC structure, which is reinvigorating. It was recently reauthorized in December of this year and will be moving forward, and has as a part of its bones crisis and the support of crisis services and the development nationally to take them to scale. So thanks for that. What I'm going to be doing is talking just a little bit about the superstructure, the organization of the paper. Then I'll turn to Dr. Shaw, Dr. Blinna Shaw, who is a child psychiatrist, probably known to this community because of her work in crisis services development. And then we'll be having a bit of a demonstration of effective crisis services in Baltimore City, Dr. Ronald Means. And then in Arizona, as a component of the Arizona model, Dr. Margie Balfour. So these are the documents themselves, and we'll be putting a link in the chat there. So we are pleased to announce this is a document, and as David represented, highly anticipated effort and release between SAMHSA and NASHPD in order to further the field in much anticipated documents highlighting the unique needs of youth in crisis continuum. So these are two documents. We really recommend them as a companion. The document that's got the blue tones to it has broader information about crisis services and related implementation, and then the black and white document is a bit smaller, more specific, more focused on the details. So we recommend accessing these documents together. I will go ahead and say that we did sort of to the exchange that Dr. David and I had earlier about the children are not just little adults. That was a point of debate as we developed this document, and is part of the reason that the document was a little bit later in its coming out than we would have otherwise expected. Where on one hand we value the concept of someone to call, someone to respond, and place to go. There was a bit of debate, particularly in the child spectrum, about place to go, because we really wanted to. On one hand, we want to preserve families and home care wherever possible. We don't want to remove children from homes. On the other hand, we recognize that sometimes, at least in the short term, that really is the only way to resolve the crisis at hand, is to have the child in a safe environment. And so we had some ongoing debate about that. I'll just go ahead and say about that. So let's go on to the next slide. These are some of the longstanding principles that are in the document or incorporated in the document, from which the youth guidelines were based, or on which they were based. So the concept of 988 Suicide and Crisis Lifeline. They were informed by the adult guidelines. They were informed by systems of care principles. That's a longstanding program that we have that asserts really strongly that children, particularly complex children, can't be addressed with single shot, interventions. They need often a team of individuals that are involved, including things like social services, criminal justice, Department of Education, and things like that, other systems that are involved in these particularly more complex needs of children. Trauma-informed care guidelines are woven into this document, as are youth, family systems, and provider expert opinion from experienced individuals in these categories. Community-based examples are in the documents, and a recovery focus to the extent possible as applies to children and their services. Let's see, let's go into the next document. Our next slide. And this is sort of a placeholder for me to emphasize that really, all in all that we've learned for many years about children and working with children is children by and large are largely dependent on adult caregivers. And so safety of the child is, we haven't abandoned the notion that safety for the child is the paramount priority in working with children, and is a little bit distinct in that way from working with adults who are largely independent individuals, whereas children, by nature of their age and development, are independent. Sorry, I've got that backwards. Dependent, children dependent. Now I'll turn over to Dr. Shaw, who will go over a little bit more specifics of the document itself.
Thank you, Dr. Everett. I'm excited to be here on the Crisis Jam at the beginning of the year, and I am excited to have participated in the release of this report. I'm a psychiatrist, child, adolescent, adult, and addictions. Just started with SAMHSA about 6 months ago, and I read this report on day 3. So it's been with me from the very beginning, and excited to be a part of it. I'm going to go a little bit over this infographic, and I really just want to focus on, I think this infographic gets at the heart of the report in itself. It's impossible to go over this whole report in 15 minutes, so we're just giving you some really big high-level highlights. But at the top of it is that the crisis is defined by the youth and the family, or the family. And I think that especially when it comes to priorities, that the priorities can differ between family and youth, and also provider networks, that things that a provider might not feel are important could be important to that youth or family. So that's really the core, is the crisis is self-defined by the people that we serve. And so, as mentioned before, the triad of a framework that we know well has been shifted a little bit. And I just want to focus on some of the major shifts. So someone to talk to, although this has somebody with a phone here, we do recognize and realize that youth, young adults, they're accessing 988 and services as much as possible through text and chat and other means. So we just want to highlight that's important to incorporate in all system building, including in the service delivery, in as much as possible. That someone to talk to needs to be ongoing, but also in a format that is very much amenable to how those young people are going to be to accessing care. Someone to respond in a developmentally appropriate way and in a developmentally appropriate place, whether or not that's schools or homes or elsewhere in the community. That we just want to make sure that we're meeting youth where they are, and that the people that are coming out to meet youth understand the specific and unique needs of youth. And finally, a safe place to be. I'll go a little bit more into this in detail, but just a safe place to be does not have to be outside the home. But we do also recognize that there are some youth that don't have homes. There are some youth that don't have safe homes, and there are some communities that might not have other alternatives for a youth to be safe. So that safe place to be is intentionally meant to be somewhat vague. And then there are core principles that I'll discuss a little bit later, but at the heart of it all is that there's no wrong door, and having a breadth of a service array really gives that ability. And so, Anita showed that the stair steps, if you will, of the other guidelines and other reports and principles that SAMHSA has carried and really helped to inform this report. And I just want to go over some of the adult guidelines and look at them, and let's just look at them quickly with the nuances of thinking about youth. So addressing recovery needs. When you think about youth and recovery, and you think about the developmental phase that they're going through, that when you're developing your own identity, what is recovery, right? Recovery looks very different when you're thinking about what is my health, home, and community and purpose. That's how we think about recovery at SAMHSA. And so at this critical developmental period, recovery needs to be focused on not necessarily recovering back to something, but blossoming or moving forward. I love the concept of, for example, post-traumatic growth, which moves me a little bit into the next one, about not necessarily letting that event be something that will stymie or halt development, but that it can also catapult into health, home, community, and purpose. Just like post-traumatic growth can have someone can come out stronger. And so trauma-informed care, preaching to the choir here, everyone knows that trauma is important. I put a little bit, a little ACE pyramid over in the right corner. And I think of an example that always rings true to me. If a friend has a small dog, it rains, the dog freaks out. An adult goes out in the rain, we put on our raincoat and our rain boots, and we think we're fine. Right? It's the perspective, and trauma-informed care is so important for youth because of that perspective. When the world we're still understanding what is safety, that it's really important for young people to be served in trauma-informed environments. Peers, going back to peers, and this includes peers for the young people, but also peers for family. Peers are so important because they are their world in this developmental stage of identity formation, and the time when adults are not cool and necessarily not always should be, so that youth can develop who they are. That peers are even more important and really shouldn't be an optional element of crisis care. And also for families where parents are navigating these systems and their own feelings, then we need to make sure that we are supporting them as well. The youth suicide rates are escalating, especially for subpopulations. We're initiating a line of work on Black youth suicide at SAMHSA because of those escalations, LGBTQ youth, as well as the longstanding concerns with AIAN youth and suicide, are just to name a few. Suicide safer care has to be focused on youth. Just thinking about development once again, how we're having kids who are dying by suicide when they don't even developmentally even understand what death is. Like, that is just distressing when you think of it in that way. So we really have to think about suicide safer care and going down to our youngest stages. And then next, safety and security. I won't go back over that. I think Anita's highlighted it very well. And then finally, that if we don't include the partners that are often the unfortunate defaults in our system delivery and development, then youth will end up defaulting back into those systems. And when you think about the school to prison pipeline, some people also call it the cradle to prison pipeline, that it's even more so essential to make sure that we're engaging our partners so that they can stay in our healthcare delivery systems. Next slide, please. So the systems of care principles, I think that when we're thinking about youth guided, for example, this is not necessarily just in the care delivery, but also in development of systems, from the creation of the system through evaluation. And we also, I won't focus on this too much, but just as a child psychiatrist, I love doing child mobile work because I was able to be in the community and seeing those different systems and networks and the interagency collaborations. And if we don't think about how to connect and collaborate, then we really are creating a symphony of chaos. And so we really have to, and families are already distressed. And we're just throwing more things and suggestions and this program and that program and that person at them. But we have to really be collaborative, especially for young people and family focused so much. So the core principles, I think these are the core principles in the guidelines. And at the end of the day, I think that I've really provided them. You can see how they've been extracted from other elements. And so we'll move on. A safe place to be. Nondescript bricks are intentionally focused on keeping youth in whatever that setting may be. Stabilization, we would hope for it to happen at home, but it may not be happening at home. It may have to, and it may occur over a longer period of time, as the crisis may have been brewing in some type of relational way, whether or not that's school or home or other community-based needs. And stabilization centers are a good resource to have in the crisis continuum for those youth who aren't able to be stabilized in another setting. And at the end of the day, we do not want youth out in emergency departments, in jails, but we do acknowledge that emergency departments and hospitals may be the safest alternative for some youth in some of the communities in some situations. So I just wanted to focus on that. So I'm going to move on to our mini exemplar presentation because we have a broad presentation, but I want to just get into a couple of programs. Dr. Ron Means is a child, adolescent, and forensic psychiatrist. I'm throwing it, unless you want to do addictions too. Well, you do addictions, you just, yeah. Anyway, and Chief Medical Officer of Catholic Charities of Baltimore.
All right. Thank you, Dr. Shaw. So I'm here today to talk about our B-CARS program. For those of you who are unaware, in Maryland, Catholic Charities of Baltimore actually runs an array of mental health programs, traditionally based in child mental health services, although we treat adults as well, but through residential treatment, therapeutic schooling, a history of treatment foster care, as well as a number of outpatient clinics as well. But beginning in 2000, in collaboration with University of Maryland and Johns Hopkins, the B-CARS program was created in an effort to try to respond to the increasing demands upon emergency rooms, kids presenting to the emergency room, needing some sort of higher level of care, but not really needing to be hospitalized. So needing some type of intervention services in order to help stabilize them. So there have been many iterations of the B-CARS program over the past 20 plus years. And has included mobile response, urgent care, school response, Department of Social Services, stabilization, actually embedded hospital diversion. So having our workers in emergency rooms to be sort of an immediate handoff point for the emergency room staff, respite services. But currently we have two service lines. We have our traditional program, which is a 2-week program that involves an initial crisis response and then 2 weeks of stabilization services afterwards. And the goals should be apparent, but just to lay it out, the goals of our traditional program are to avoid inpatient hospitalization, work to stabilize crises, and then link children and families to long-term services that are appropriate to meet their needs. And then our second service line currently is our Baltimore City Department of Social Services stabilization arm, which is essentially an expanded version of our traditional arm that can work with kids for up to 6 weeks in order to help provide, all those goals that we talked about previously in our traditional arm, but also help specifically for placement stabilization for youth who are in foster care, knowing that, as there are, increasing number of disrupted placements for youth in foster care, that the outcomes worsen with the number of placements, as the number of placements increase. So our traditional program began around 2000, and then our current DSS stabilization arm began around 2009. We have ongoing partnerships with University of Maryland and Johns Hopkins in order to collaborate regarding hospitalization, ER visits, although we're not currently embedded within those facilities. But our services that we offer as part of either of our service lines include a 24/7 hotline, mobile crisis response to Baltimore City Public Schools. So if there is a crisis within the school system, the schools can call us in order to respond within an hour in order to respond to those crises. We have an urgent care clinic, which essentially serves as our a crisis response model where we get people in very rapidly to be seen within our office for both assessments as well as psychiatric evaluations and medication management. And then all of our stabilization services after those initial assessments are community-based interventions, all mobile, including short-term intensive individual and family therapy, as well as psychiatric rehabilitation services. And then we offer 24/7 mobile crisis response to DSS, to all DSS clients, as well as our clients that are currently enrolled in our programming in order to meet their needs if they falter while in the program. It's been interesting because the best data that we have was a 2014 study that was done by the University of Maryland School of Social Work that very clearly showed, particularly for our embedded ER stabilization arm, that not surprisingly, when crisis intervention services are done correctly and there's a stabilization arm to it, that you can see reduced costs for long-term inpatient psychiatric care as well as emergency room care. And then we were very happy to see increased costs for outpatient care. So because we're linking people to outpatient care, they're getting connected and hopefully having more stable, long-term, better outcomes. The cost of outpatient care went up, which is was a welcome response. So, it's probably the best data that we have that shows both the initial crisis response as well as long-term stabilization services are tremendously beneficial.
Thank you so much, Ron, about talking about BCARs and the data that you have that shows how effective it is. We're going to move on to Margie, no stranger to the Crisis Jam.
Hi, and so I'm going to talk really fast because of time, but I'll put my email in the chat. So if anyone has any questions, feel free to email me. But I'm going to be talking about our Crisis Response Center in Tucson, which exists within a larger crisis system, but this is really that safe place to be component. We serve about 2,300 kids annually, along with some adults. And it really came about as a community partnership. So the county built the facility, and they put up the capital costs for the building. The services are funded via the Arizona Medicaid system, but uses a braided model so that we can serve anyone regardless of their payer, as someone mentioned in the chat. And then we've been operating it on coming up to our 9th year now. And it really has meant, that no wrong door concept to be easy access to care and the ability to take everyone. So people can come in via walk-in and mobile and ED transfers. A quarter come from the police and we get them really, get them in and out as quick as we can. But we accept everyone, including those really high acuity people, because these are folks that, maybe some of the crisis residential programs in town can't take them when they're that acute, and they would tend to, in other communities, go to an emergency room or default to the hospital. And our goal, especially with our 23-hour observation unit, is to get them stable and stabilized quickly so that they don't need to go to the hospital, so that they can either be connected to community-based care or step down to like a group home or a brief residential placement while that whole family has their crisis worked on. And there's some stats there at the end too that I think just one important thing to note is that we're seeing an upward trend of that 8 to 12-year-old. So that's risen from like 20 to 26% of our volume over the last 6 years. So but basically, the thing that makes it work is community partnerships, especially, working with DCS and working with our other schools and other service providers. So thank you.
Those are two great examples of a safe place to be. And I don't know if Anita, you have any final quick words?
No, just thank you. I've put a few things in the chat that relate to questions that came up, but I did want to thank, our presenters, Dr. Balfour and Means, and also you as well, Dr. Shaw. Hope we'll stay on just a bit in case there are other questions, but thank you so much for taking time out of your busy lives to share your work with us.
Tremendous. And thanks for the leadership of all those involved who helped drive this new vision and blueprint. So let's go to Shamika Williams, leading Children, Youth, and Family Services at the Oklahoma Department of Mental Health Substance Abuse Services.
Well, thank you. So first, let me just say thank you to SAMHSA, of course, the Quality Learning Collaborative, formerly out of the University of Maryland and now out of the University of Connecticut, for the work that they have done around crisis care services for kids across the nation. I think this guideline is a great foundation to really what we can expect to transpire to happen across the nation in many, many states that are working on crisis services for kids. One of the things that I want to reference is really the someone to talk to and someone to respond. Really in our world, we talk about that as someone to connect. I think from a parent's perspective as a parent, we often want someone on the other end of the line that can really help us to navigate through the crisis scenario. Someone that will talk to us in a way that helps us to really understand what it is that we are, what's involved, what are our kids going through. I think oftentimes parents don't have the means or the resources in order to support the problematic behavior. So really the someone to talk and the someone to respond is really around making those connections with parents very early on in the process of a mobile response system. And so 988 is going to be really great with how connecting with parents in a way so that they have the support that they need in order to navigate the crisis. I think it's also important as a part of the crisis, the guidelines to talk about. Families really need to be a part of the decision-making process. I think that oftentimes when we talk about kids who are suicidal or young people who are at risk, we think about the involvement of law enforcement and how those law enforcement officers or first responders can support. I think it's really important for us to really get the parents involved in that, ask for their permission. In most cases, kids have a supporting and a safe environment, although they're in crisis. So really asking the caregiver or the parents, would you like for law enforcement to be involved in this type of response? Can we contact law enforcement to aid us in these types of response? And I think it's equally important for us to partner with our law enforcement officers across the nation to really create opportunities for training when it comes to young people in crisis. We often know that sometimes the response do not have the outcomes that we wish, especially when we talk about Black and brown people, especially when we talk about kids that are at high risk. And so partnerships with law enforcement are extremely important when we talk about creating a mobile response and stabilization system for kids and really getting the parent or the caregiver involved in how do they want this response to take place. I also think it's really important to really think about pathways of care. When we're talking about partnering with our community partners, there was a mention by Dr. Everett around partnering with systems that support kids that are in higher levels of care, whether we're talking about the Office of Juvenile Affairs or we're talking about school systems, and really looking at the uniqueness of navigating crisis services from a community standpoint. Oftentimes we can create a much more preventative, interventive system instead of allowing individuals to continue to maintain on the crisis system. And so really creating pathways where we intervene at school systems, where we intervene with youth who are LGBTQ or homeless youth. And so really looking at the unique ways to serve them in a much better capacity. And I think also another important thing is, we often heavily over-rely on our emergency rooms and our and places where kids can get help now. It's important for our 988 crisis system to be an immediate response type of system. And the reason why I say that, because as a parent myself, we have been trained to utilize 911 and trained to utilize emergency rooms as the place for first response. If your kid is in a medical emergency, the first place you're going to go is an emergency room. So our 988 system has to be a system that connects, that responds, that involves caregivers, that involves parents in the decision-making process as to how they want that response to happen. And I think also the first and foremost, we really have to go back. There was the video and we had a conversation around really looking at the idea of stigma. Young people are ready to talk about this, but how comfortable are we about the conversation? I think oftentimes when we think about stigma, we think about it on a broader context, but we have to think about it in reference to parents, professionals, and peers. Many times parents are not ready to have the conversation. Many times as professionals, when those conversations come up early on, whether it's a young person in treatment, that can be a definite uncomfortable conversation. And then also with the young people, teaching peers how to have these conversations as a part of really addressing the stigma around mental health, suicide when it comes to young people. Again, kudos to SAMHSA for the work that they've done on this guideline. And again, thank you for allowing me to be a part of this jam session today.
Shamika, thank you so much. And thanks for everyone for their leadership. There's so much rich stuff and some questions still not attended to, but let's keep that going in the chat text and throughout the rest of this jam. Hey, we have every week a highlight of the, as I move quickly on to the next segment, we have every week a highlight of the shop that you can go to for t-shirts. But the SAMHSA store actually has a host of items available to you. You can get up to 326 free items through SAMHSA, and we're going to put the link to that in the chat. But if you're in the Crisis Trivia hot seat, you can get a shirt, a hat. If you're not in Arizona, a long sleeve shirt. But let's jump straight through. Chelsea Booth is in the hot seat today, a long-term friend of the Crisis Jam with EDC and now SAMHSA. Chelsea, are you with us?
I am. Happy
I
New
don't
Year,
know
everybody.
I don't know, Chelsea, if you happen to see the Washington Post poll recently highlighting the differences in communication for boomers all the way to Gen Z. But as we get into more online, this connection that's been talked about becomes more important. So one of the, and we'll put the entire poll into the chat, but one of their recent question was, you assign your Gen Z colleague a task on Slack and end the sentence with a period. What's risky about this message, Chelsea? Chelsea, are you Gen Z or a millennial or?
I am some of the youngest Gen X, so I am old compared to this. And is this a setup? Did you ask me a language question because you know I'm a linguistic anthropologist?
I didn't remember that, Chelsea, actually. So you have to get this right, Chelsea.
I do.
And the audience will help you.
Okay.
This is risky because Gen Z hates Slack. It's risky because Gen Z only reads messages that arrive via email. It's risky because Gen Z might see this as a mere suggestion, not an assignment, or because they might see it as a sign of anger or coldness. The audience, let's put up the results. The audience is all over the board, but the dominant one is D, might see it as a sign of anger or coldness.
I think that is, I did not read the article, but I do lurk on TikTok and follow someone who was talking about this the other day. So I'm going to go with D.
Yeah, and that's the answer. So Gen Z grew up communicating digitally and may use punctuation differently. Young people, certainly in text and chat, tend to omit this kind of punctuation, believing periods don't really serve a purpose anymore in that context. So a full stop may sound angry. Chelsea, thank you.
Happy to be here.
So Chelsea, coming from Gen X, let's have a Gen Z. My son, William, we heard William's actually 14 yesterday and 15 today. So happy birthday, William. Welcome to the Crisis Trivia hot seat. William, I don't know how much you're tracking what's going on in your own school district. We referenced the Washington Post article, but after several suicides among students in Chandler, Arizona, a debate was ignited about what schools need to do to support students in despair. And last month, the Washington Post highlighted a coalition seeking mental health first aid and much more to elevate mental health concerns. Who started this group that the Washington Post was referencing? Was it Chandler psychologists, Chandler students, Chandler parents, or Chandler teachers? You can phone a friend. You can think about it out loud. What do you think, William? What's going on in your head?
All right, I'm gonna be straight up here. I don't think the teachers, parents, or psychologists are competent enough to start this kind of thing. Look,
hey, let's get Chelsea back to explain the aggressiveness of this Gen Z crowd. Savage, somebody wrote in the chat text. So you don't need the audience's feedback on this. The audience actually predominantly 90% will say it's students.
Yeah. I mean, I also have a friend that's texted me before about this thing she does, and I don't remember exactly what it was, but it was something a lot related to mental health, and she goes to CUSD. So I just want to assume it's students. And also, I don't even know if my school has a psychologist.
This was a terrible idea.
And
Vinnie
then
Morrison, Megan Hott, what was I thinking?
Sorry, I'm thinking here. And then like for the teachers, I don't think the teachers are that engaged in their students' lives. And I don't think any of them are getting
okay,
paid
so
enough
we're
to
moving
care.
on to the answer here. The answer is students. Well done, William. You get a t-shirt. Rihanna Alexander is, do you know Rihanna by chance, William?
No.
given your sass on this call, we're tasking you with getting Rihanna on a future Crisis Jam. That's what you get for being involved in the Crisis Trivia Hot Seat.
I'll try.
Thank you. Rihanna, mental health is hard. It's hard to talk about. It's hard to struggle with, and it's hard to open up about it. So she started the Arizona Students for Mental Health, which was highlighted throughout this tremendous Washington Post article. Thanks for joining us. Happy birthday, my son. All right, let's go on. Will's 15 today, but Haley was 14. She was actually, I think she says 15 and a half in the video we're going to show. Stephanie, you had a chance to interview Haley, who was the Rihanna Alexander 10 years ago.
That's right. Yeah, and Haley right now is the executive director at Arizona Peer and Family Career Academy. But when she was 13 years old, she did not find youth-led supports. And so she created it by partnering with NAMI and Magellan. Haley, can you talk a little bit about the impetus for getting those supports started?
Yeah, it started really with my own journey. There wasn't the support, right? I think Will alluded to it expertly. The adults around in our system, especially if we think about what our system looked like 10 years, it was so drastically different. And there wasn't enough support for me as a young person. And I knew, hey, if I'm the only person, you know, I'm not the only person here, right? And so being able to connect with other young people, and we led that group and program and helped expand it across our country in multiple different states at the time. And it also created a foundation for me to say, hey, let's continue to use lived experience in a valuable way and increase lived experience professionals within our system.
And as we look, 988, you don't just, flip a switch. People can dial 988, but these systems are being scaffolded and expanded. What would you say to leaders as they're navigating that? What do they need to consider when we're talking about youth-led support?
I think it's so important, right? We just had that poll where it was talking about language and connecting with young people. If we're using a chat box, right, paying attention to those text messages and how we're using those wording, what is up and date, and keeping in mind, right, young people change, and with each generation, with each year, the lingo is different. And so making sure that we're keeping up with that, but also involving young people in our processes. I think it's great that Will was on here. I started youth work 10 years ago, over 10 years ago now, and I'm no longer a young person, but I do think it's so important that we advocate and speak for young people to make a difference.
Haley, let's see you 10 years ago. So we're going to put a link to a longer video in the, it's about a 5-minute video that we're going to put in the chat text. But this is a 2-minute segment of that video. And this is Haley before local legislators, policy leaders, radio and TV. It was, and Haley was part of a group of, there were many, but 6 or 9 major ones over the course of some years. Oh, wait a second. Let me do the sound again. Oops. All right, one more time here.
My name is Haley. I started taking college classes when
All right, sorry about that. Hold on. Please hold. There we go. Okay.
My name's Haley. I started taking college classes when I was only 14. Now I'm 15 and a half, and I'm a youth advocate. I meet with elected officials and CEOs of major companies to advise them on important issues affecting youth. I'm helping change the world. Oh yeah, and I have mental illness. So do 1 in 4 adults.
My name is Xavier, and I emerged from the darkness as a rebel MC. And now I travel in the light, and now the better I see. I'll illuminate mystic relics and spit angelic phrases. I'm divine when I rounded it astounds and amazes. I'm the equation from the final combination. I bless the population, move the ground and rock the nation. Oh yeah, and I have a mental illness. but so do women for adults.
My life is a youth group, and we're made up of youth ages 13 to 23 who have experienced with mental illness, substance abuse, and or foster care. Just because we have those labels on us, that really isn't us, and everyone sees that as who we are, and that's not who we are. We have our own voice.
All they saw was someone who's like, oh, he's schizophrenic, he's paranoid, and he has anger problems. But here at My Life, I really have a chance to show the real me.
Just because you've always been told your voice doesn't matter, it does matter. You can make a difference. And that's what My Life is all about. The group is completely ran by us. We run our meetings, we run our events, everything. So it's a way for us to take control and for us to get involved and, you know, just make a difference in our community.
So Haley, any last sort of reflections as you watch that video of the work that you guys all did together back 10 years ago now?
No, I think it just really highlights, right? When you give youth the opportunity to have a voice and to come together and be leaders, they rise to the occasion. And it took so many of us to make that program possible. And, you know, looking back at that video, it's amazing to think of how many of us have gone on and achieved great success, that we defied many statistics that we could have fallen to based on different characteristics and situations and experiences we had. And so, you know, listen to youth and bring them to the table and let them make a difference. You'd be surprised.
Love it. Love it. Listen to youth. All right, so let's go to Dr. John Palmieri.
Thanks, David. Yeah, I'll just try to be quick here in the interest of time. So a couple of funding announcements that I think many of you have been tracking. One that was issued over the end of December related to the BISCA funding that we've talked about previously. So 23 awards to tribal nations, tribal organizations to support 988 response, as well as 51 supplements to states and territories, again, strengthening 988 response. And then I'm sure many of you have been tracking the omnibus bill that was passed that includes a little bit over $501 million to support 988 in FY23, which is about a $400 million increase over the base in FY22, and has a lot of language to unpack in the authorizing language, but importantly does codify the coordinating office as a key component of crisis transformation. So there's lots of good stuff there, and we'll talk a little bit more about that in the coming weeks. Also wanted to flag that the 2021 version of the National Survey on Drug Use and Health, or the NSDUH, which is an annual survey measuring key substance use and mental health indicators in the United States, that is being issued, released this week, and there'll be more briefings coming up for partners over the coming week on that, but does include some increased measures and selected estimates by race and ethnicity. So again, working to disaggregate data when we can, improve data collection, making sure that we're looking to improve disparities, and always thinking about how we're working toward equity as we're thinking about the crisis system. And then finally wanted to let people know that we have officially selected a new director, a permanent director for the 988 and Crisis Coordinating Office, and that will be Monica Johnson. I'm very pleased to report that Monica will be starting later this month. And I think many of you on this call know Monica. She's just been a tremendous leader and advocate in behavioral health space in Georgia. And there'll be more to come on her transition to SAMHSA, but very excited about her arrival in the next few weeks. And I think Richard's on the call. Richard, I'll hand it off to you if there's anything else you wanted to say quickly.
Thank you, John. I'll just mention a couple of things. We were very pleased that there were increases in many of our suicide prevention programs. There is a $5 million increase to the Garrett Lee Smith State and Tribal grant program, to the $2 million to the Campus Suicide Prevention Program, $2 million to the SPRC, $5 million to the Zero Suicide program, $2 million to the Native Connections program. So we were glad for that. There were also some changes in the authorizing language, which are important. So for the Garrett Lee Smith State and Tribal, which historically has been age 10 to 24, that lower floor has been eliminated. So it's now up to age 24, which allows for more early prevention activities going more upstream than was we were able to do previously. Also for zero suicide, which had been restricted to above age 24, for years because of statute, that's now been changed. And it just says adults, which means that we don't have to worry about there being a problem with those over age 18, particularly that 18 to 24 group. And if you haven't had a chance to do weekend reading, looking at the 4,000 page FY23 omnibus appropriations and the attached authorizing language, I suggest that you would do that. The authorization for the Lifeline has gone from about a paragraph to about 8 pages. There's lots of authorizing language regarding the 988 office, regarding the continuum of crisis care. There's also now authorizing language for our mobile crisis grant program, the Community Crisis Partnership grants, which will also increase from 10 million to 20 million. So I will stop there. Thanks, John.
Wow, tremendous work and great news, John. Monica Johnson will be a tremendous addition to this leadership team at SAMHSA and this federal state partnership that we're seeing at unprecedented levels. She will bring so much to that rich equation. Let's go to Michelle Zabel with NASHBIT.
Thank you. So my name is Michelle Zabel. I'm Executive Director of the Innovations Institute at UConn School of Social Work, and I'm in the chat. One of my co-authors, Denise Sulzbach, is dropping a link to the NASHBIT publication, A Safe Place to Be, Crisis Stabilization Services and Other Supports for Children and Youth. And so this is part of the Beyond Bed series that NASHBIT has been doing for the last couple years, and it specifically focuses, because we're doing youth today, on the components of a robust crisis system continuum that's really a safe place to be. The part that is about the components of customizations needed for home and community-based crisis stabilization services for children, youth, young adults, and their families. And I'd just like to argue with Richard, once you read that 8 pages or even the whole 400 pages of the omnibus bill, please take a minute to read this as well. This document provides not only those components conversations, but also recommendations for policymakers, purchasers of service, those are who are doing Medicaid state plans. And we'd like you all to know about it and use it and read it so that you can operationalize what my colleagues across the country presented today. I want to thank SAMHSA, NASHBIT, everybody who's leading this work and for focusing on youth and families. It is important. And obviously, if we want to turn the tide on our crisis of children's mental health, setting up crisis services that really create opportunity for youth and families is important. So please read it. Please email us if you have questions. Email us if you have thoughts, concerns, opportunities to partner. And thanks for having me.
Oh, terrific, Michelle. And Vic Armstrong.
What's the word? Word, strong talk, strong talk. What's the word? What's the word? What's the word? Yeah, yeah. What's the word? Strong talk, strong talk.
But Vic's not here today. He's on leave. So we have Preston Mitchum, who is in his place from the Trevor Project. And Preston, let's go about 2 minutes over today. And look, that's not our norm, but we want some strong talk from Preston. And we're going to put in the chat text a link to the blog he wrote, Black Queerness is Magic, on the Trevor Project. Preston, bring us some strong talk.
All right. Thank you so much. And I appreciate everyone staying on a bit longer. I promise you will enjoy it. So I am Preston Mitchum. I use he, him pronouns, and I'm the Director of Advocacy and Government Affairs with the Trevor Project, and really grateful to be here today. It is equity, not equality, that should be a through line in everything that we do. And I must start boldly to explain the difference, because as I often explain it, the difference between equity and equality is that equality gets everyone the same thing, while equity gets everyone what they deserve. In a world without an equal playing field, equality will never serve the most marginalized communities. Equity matters to my entire existence. I am Black, I am queer, I'm from a poor community in the Midwest, and I have familial roots in the South. I have hypertension and have a family history of cancer. I'm also a survivor of sexual assault, and all of these are important for me to remember as I navigate the systemic and structural harm of white supremacy and queer antagonism. I want to talk about how we have seen equity or lack thereof play out in everyday systems, including healthcare, and especially why equity beyond a mere buzzword is crucial for everyone's work, including my own. And it's important for me to start with what has yet to end, COVID. The expression of when white America gets a cold, Black America gets the flu has always rang true, but for many people, and especially young people, rarely has it resounded as significantly as it has during the coronavirus pandemic. That expression shifted from words to reality time and again, with stark disparities in education, housing, voting, employment, healthcare, and the criminal legal system. In the beginning of the pandemic in 2020, when we first saw race-based data about pandemic-related deaths, the numbers were devastating. It's also when we noticed youth being blamed for the spread of the virus. It's partially why in 2021, I wrote a chapter in the book, The Black Agenda, Bold Solutions for a Broken System, about these stark disparities caused by institutional harm. It also wasn't about any singular person. I'm reminded of Audre Lorde's quote, "We don't have single issue struggles because we don't live single issue lives." Black and LGBTQ youth, for example, are disparately impacted by lack of culturally competent and responsive healthcare, especially in mental health care and suicide prevention resources. 988 also shows us the importance of equity. We all know that 988 is one of the most transformative things and items in history. It's also an opportunity to transform stigma and discrimination that's ordinarily tied to mental health care for marginalized and historically excluded communities. If implemented effectively, and we're seeing good results now with strong infrastructure, a culturally competent workforce, and increased funding, it can and will and already has saved lives. Yet it must be grounded in an equity lens. So today I have a call to action for each of you. What will you commit to today to elevate equity within your community, in your field, and in your organization? How will you center youth in your work? Write it down, save it for yourself, and then work together to hold each other accountable. Perfection should not be the enemy of the good, so it's time for us to continue these courageous conversations, starting with prioritizing equity. Thank you.
Wow, thank you so much, Preston. Terrific, strong talk. And we're going to look for other guests. Vic's going to carry a lot of these, but Preston, thank you. And we'll look to have you again. Preston referenced something that really relates. Misha Kessler's Moving America's Soul and Suicide video will be out in the next week or so, or close thereafter. Growing up gay and closeted and living in New York. Is going to tell his story. And coming up, we will have Jason Friesen this coming week, Trek Medics deploying emergency responders. And I wanted to bring your attention to Megan Jones-Bell, who's going to come from Google to share with our learning community on February the 1st. And with that, thank you so much to Dr. Belina Shaw and Dr. Anita Everett, and to all of our participants in today's special edition. Happy New Year to you, and look forward to seeing you again in the Crisis Jam soon.